hello to all of our East African colleagues. We haven't had any of you dial in for this March 18th lecture. Um, we're concerned that perhaps with COVID-19 and the sequestration and increased bandwidth usage, perhaps there's a interference in allowing you all to dial in with us, but because this is such important information and because we have Dr. Doug McMillan here to teach us about kangaroo mother care, we're going to go ahead and do the presentation in a recorded form. Again, I'm Dr. Amy Wood. I'm the lead for Kenya. I'm a neonatologist and I have been working in the Kajabe Hospital since 2009. And in the States, I work for Our Lady of the Lake Children's Hospital. Okay, Doug, would you introduce yourself and tell them a few things about you?
Good morning, and thanks very much for the introduction, Amy. As you can see, I'm sitting here with actually a bear in the kangaroo mother care, and I'll show you a little bit more about that later. But part of this is to emphasize that even men can do kangaroo mother care. I've been involved with global health teaching for over 30 years and have had the opportunity to actually speak and participate in learning sessions in many parts of the globe. More recently, I've realized that perhaps the presentations like this or the lectures like this are not the best form of learning. And so I've been involved with the Helping Babies Survive series, the Helping Babies Breathe, Essential Care for Every Baby, Essential Care for Small Babies, which focuses on small group interactive learning. More recently, and as you'll see in the presentation, we've been involved in a learning program related to kangaroo mother care, in which we're trying to take the recommendations that come from various bodies, including UNICEF, Save the Children, etc., translate that into the same or similar kind of interactive program and combine this with some quality improvement skills to enable people to more successfully implement kangaroo mother care programs in their own centers. I'm recently back from Tanzania, where we were doing some pilot testing of this program, but I've only had a chance to teach in Kenya once. I was Helping Babies Breathe, but I've done a fair amount of work in Uganda and other areas of the world, including Asia. So let's start then with kangaroo mother care more than warmth. As many of you are aware, there's three main groups of causes of neonatal death, the over 2.5 million that still occur in the world each year. Approximately a quarter of the deaths are related to asphyxia, and the Helping Babies Breathe program helps address that. Approximately a third are related to infection, and that's addressed in a variety of ways, including the Essential Care for Every Baby, but also in the kangaroo mother care as will come. And then the preterm, which is another quarter to a third. The others are relatively small in numbers. When we're talking about the preterm here for the sake of this presentation, we're going to be talking about the well preterm. We're not going to talk about how to provide assisted ventilation to a 24-week gestation baby. That's a much more complex care endeavor. We're going to talk about how small babies who are otherwise well can benefit from kangaroo mother care. Well, this was started off as a topic related to temperature. And so I thought I'd start just by talking a bit about temperature. And we've known since the days of Joe Daly, that probably 50 years ago, that babies who are otherwise well, preterm babies, otherwise well, when they're admitted to the care unit and they're cold, that this has bad effects on their subsequent outcome. Having the babies have a normal temperature, improve survival, decrease morbidity, enhance feeding ability and weight gain, and methods may assist stabilization after birth and also improves adaptation after birth. This was first described from Colombia then many years ago, 1978, where the people in Colombia had been using incubators to keep babies warm, and they ran out of incubators. And they realized that putting multiple babies in incubators exposed those babies to hazards, such as one baby gets infected, all the babies get infected. It didn't allow for any individualization of temperature control. So they studied and reported the benefits of the mother keeping the baby skin to skin throughout the day until the baby got big enough to maintain his or her own temperature. Subsequent to that, there have been a variety of programs that have endeavored to copy this with variable success, but we'll see that in just a minute. Let's just start with the normal temperature right at birth. There's 4 ways that babies lose heat. First of all, evaporation. As the water evaporates, it takes heat with it. And so one of the things that we're taught with helping babies breathe and a variety of other resuscitation programs is you dry the baby. The second thing is, it's convection. Wind blowing over the baby, we avoid drafts. The third is conduction. We don't place the baby on a cold surface. And finally, radiation. We don't place the baby near a cold wall. Now you can think yourself, what would happen when you've been in a nice warm bath and suddenly a big chute opens up and you're outside in the cold wind? What would you do? Well, you try and drive yourself off. You try and get out of the draft. You don't want to sit on that cold stone, but you might try and find a source of radiant heat, maybe some other warm body next to you. This is the reason why we want to place the dried baby skin to skin on the mother's chest for 1 hour after birth while monitoring the baby. And this is a recommendation now that for everyone that this should occur to start the baby off right. Now, there are some other things that you can do for the very tiny baby, and that is that people traditionally have used increased wrapping or clothing. Well, that doesn't work very well, and we'll see that in a minute. For the very tiny babies at birth, those less than 30 weeks gestation, we know that if you just put the baby in a plastic bag, that will cut down the heat loss tremendously. You don't even need to dry them, but just place them in the plastic bag up to their neck on there, and you can care for the baby, resuscitate the baby. But we're not going to talk about those babies today because those are the really tiny babies. We're talking about the babies that, especially between 1,500 and 2,500 grams, but sometimes lower down to 1,000 grams. You can wrap those babies, put them in clothing, and that's been traditionally done. In some places, they've had a small room that they've put an electric space heater into and kept the room very warm. You can put the baby in an overhead warmer or under an overhead warmer or some alternate source. I've seen people use electric light bulbs and a variety of other things, or incubators. Unfortunately, with the incubators, they were designed for one baby. In many cases, the incubators are acquired or even sometimes sent over by very well-meaning people, but when they break, there's no parts for them. And it wouldn't be surprising for me to see, perhaps in some of your units, that you have incubators sitting in storage where they're just gathering dust because they're no longer usable. The skin-to-skin care is almost always available, if not from the mother, then from someone else. So just to emphasize the importance of that, I want to tell you a little bit about an audit that we did in Africa, looking at the baby's first morning temperature. Now, this is in a special care unit in an NICU, one of the more developed in the country. And what we did is for over 3 days, we measured the temperature, the axillary temperature of all the babies. We can see that here, almost a quarter of the babies have temperatures, not just cold, but less than 35 degrees centigrade. You've got another, just under half the babies that have a temperature that would be considered cold. It's very few hot, and a very small percentage, here only 15% at a normal temperature. Well, how did this occur? Well, first of all, even in Africa, it gets cold at night, and many units have no external heat. Secondly, babies, there's not enough nursing staff to care for the baby, and so the baby sits at night while the mother sleeps, the baby is wet, and in the morning is cold. Going along with that, we actually did a little audit with the babies looking at their glucose. And we saw that there's a moderate number of babies, not all of them, they did better with their glucose and that, but a number of babies that will be hypoglycemic. Because again, they haven't been fed during the night because their mothers are asleep and they're separated from their baby. So we want to keep the mother and the baby together. So this concept, first reported from Colombia, done 1978, was really done because there was lack of equipment and personnel. It decreased mortality in small babies, but the replication in other centers over the next 40 years has been variable. If we look at the latest Cochrane review I could find, that was 4 years ago, here are the results. The risk ratio is really a comparison of the chances of a baby with kangaroo mother care having the problem compared to the chances of a baby without kangaroo mother care having that problem. So we can see just roughly, these are the confidence limits, and if they don't cross one, it's statistically significant. But look at this number. It reduced in-hospital mortality overall, with over 3,000 babies, total babies reported in this meta-analysis. It reduces in-hospital mortality by 40%. It reduces in-hospital sepsis by 65%. The chances of it occurring are only 35% of what it was if you didn't have kangaroo mother care. It reduces hypothermia by 72%. And it improves breastfeeding at discharge by 16%. All good things that people would say should occur and are beneficial. If we looked at weight gain, and these are now presented as grams per day, they had an increase on an average of 4 grams greater if you had kangaroo mother care than if you did not have kangaroo mother care. The head circumference increased slightly, the length increased slightly, as did the head circumference. Now, whether all of this was due to improved nutrition because the baby had better access to the breast, or perhaps some of it was due to reducing hypothermia, where the baby's using up all his or her calories to maintain temperature rather than grow, we really can't say. The length of stay really didn't decrease a lot in this meta-analysis. And there's really no psychomotor development difference at 12 months. The benefit was early on, getting the babies then to be healthier, to grow better, and most importantly, not to die. Now, of course, quality in healthcare means different things to different people. And so when we're talking, whether it be kangaroo mother care or some other program to try and help newborn babies, different people have different perspectives. Governments and hospital administrators, quality of care usually has a cost element to it. For other people, they want to know that it's accessible or that it's appropriate. Now, it was interesting in that regard because when I was recently in Uganda, there was questions then, will mothers place babies skin to skin on their chest when traditionally they put the babies on their back? Is this appropriate? And the answer was, yes, they will do that. Some people are looking for efficiency. Does this mean we need less nurses? Is it acceptable? Is it safe? And of course, with all these things, you're weighing one thing versus the other. Is it patient-centered? Is it effective? And is it respectful? Well, now let's go back and look at kangaroo mother care. It is low cost. It's not very expensive for the mother, but it may have some implications. You need, as we'll see in a moment, need some special facilities for the mother, and she needs to eat. It's readily accessible. It's certainly appropriate, and we can learn that from many animal species. It's efficient. It's been shown to be acceptable. It's been shown to be safe. It is patient-centered, effective, and respectful. So kangaroo mother care fulfills many of the different meanings of quality. I want to talk a bit about a combined kangaroo mother care and quality improvement learning program to save newborn lives, which was some of which comes from the American Academy of Pediatrics Essential Care for Small Babies, combined with the evidence-based practice for improvement in quality, which is a Canadian developed program with 10 steps. It's that program that actually implemented in the NICU has shown the tremendous drop, and just recently reported in the Canadian Medical Association Journal, the tremendous drop in-hospital mortality and morbidity in Canadian NICUs. So whereas a decade prior we were among the higher of the developed nations, now we're as good as any of the nations on that. And it's an interactive program that we're looking to move together. I want to show you this somewhat busy slide to show you then a little bit about how this program works. It uses some of the similar kind of principles, that other programs have used for helping babies breathe. Starts with a story. Baby girl born 6 weeks early. She breathes but doesn't breastfeed. The mom wraps the baby in a cloth. The next morning finds her cold to touch, and when you arrive, the baby's not breathing. And I would ask, when we give people the opportunity to reflect, does that ever happen in your center? And unfortunately, in many cases, people said yes. So here's the other baby born at 6 weeks early, breathes well, You show the mother how to provide skin-to-skin care, teach the mother to express breast milk and feed with a cup. After several days, the baby's breastfeeding well, and her mother is ready to continue skin-to-skin care at home. And it's easy to see how people feel. Over here, it asks, what is KMC? So we asked the people in the audience, usually in this program, recommended 8 per table, what kangaroo mother care means to them. And then we go through the answers are here. Continuous skin-to-skin care with the mother or another family member, exclusive feeding by breast or breast milk by another means, early continued care at home when preparations are complete. Who does this apply to? Babies usually between 1,500 and 2,500 grams, although some centers will go lower than that, who's breathing well, can maintain the temperature with this thermal care, can feed by breast or cup, or in some cases nasogastric tube, and doesn't have a danger sign or other serious problem. We're not talking about the babies on a ventilator here or on CPAP. What does it do? It helps prevent death, low temperature, inadequate feeding, infection, and there's been a suggestion that possibly this may reduce apnea. So then we go on and invite further discussion. How well do you meet the needs of small babies and mothers at your facilities? Do you have a space separate from sick babies? This is important, especially when sick means septic. Have a space separate from sick babies and guidelines to meet these needs of the small babies. And then there's some information in the background. So all of this program would have sheets like this for the facilitator to review with the participants. So one of the important things with kangaroo mother care is the readiness. Not only does the baby have to be ready, but also the mother, the family, and the healthcare provider. The baby needs to be 1,500 to 2,500 grams, sometimes smaller, no danger signs, and needs to have had essential newborn care already provided. This is not a substitute for eye prophylaxis if it's used in your center, vitamin K after birth, checking the baby over with good clinical assessment, weight and temperature on there, and emphasizing good cord care. This goes along with that. The mother needs to be stable post-delivery. No major bleeding, preeclampsia, eclampsia, or major infection. And she has to be willing to provide the kangaroo mother care. The healthcare providers need to accept the concepts and be willing to teach and assist the mother and the family. Now, some element of teaching families is part of almost all newborn care. But unlike some of the other learning programs where the emphasis is on the provider, the healthcare provider, learning to do something, in this case, it is equally and perhaps more important that the healthcare provider be able to facilitate the learning in the mother and other family members. They need to be trained to provide the support, the ongoing assessment and documentation, because now the mother is empowered and responsible under some guidance to provide the majority of care. The family needs to be willing to support the mother's needs. Dad needs to say, you know, this is important enough. The other 3 children at home will find a way to do that. And the grandmother may need to say, well, this mother needs a break on there from the skin to skin. I can help with that. Keep the baby skin to skin with me. And even someone may need to say, well, I can bring food in for that mother because otherwise she'll have no access to food. It's not all hospitals that feed everyone in the hospital. So the family and the community are very important. So what healthcare structures are required? Well, a separate room for small babies and mothers, A comfortable place for mothers to sleep. Mothers can sleep lying back, but usually have to have the head of the bed elevated because it's hard to sleep when when you're lying completely flat and the baby's on top of you. The other thing that it does, either having the head of the bed that will elevate, or in some places they put pillows under the mattress, is the mother's less likely to roll over if they have the head of the bed up. You need washroom facilities. And this mother cannot be going to another building for the washroom facilities. With the assistance of Rotary clubs, we actually just built some washroom facilities for the Kangaroo Mother Cave in Umbarara, Uganda. You need to have a place for refuse disposal and keep it clean. Provision for maternal nutrition and other healthcare needs. And the other issue is the breast milk identification and storage, especially if it should go into a common area such as a refrigerator. In many cases, that doesn't occur. Mothers pump and use it immediately. But if you do have it in the fridge in between times when mother has some excess, there needs to be a proper system for identifying it and storing it. We're not going to get into the details of pumping breast milk and how you give it. That's going to be a topic of another teleconference. We have an action plan, much like for helping babies breathe. I'm not going to go through all of it here, but it's something that you could put up in your unit. You could label it differently. People could ask about it, but it starts with preparation, essential newborn care, moving down to the well small baby, remembering that the well small baby can move into the advanced care anytime. This is similar setup as you may have seen for any of you that have taken the Helping Babies Survive series. It can provide warmth, skin-to-skin care or improving it, or it can provide express breast milk by cup or tube, and you can actually teach nasogastric tube feeding to the mother here, but always assessing for breastfeeding because we want to move the baby down to getting ready for discharge. We have to consider what the mother needs, support her breastfeeding on there, and assess her for home care also. But usually she's ready to go home far earlier than the baby. So we need to teach healthcare providers KMC, and here's just a picture of that occurring. This is a healthcare provider who is pretending that she is the mother. For those of you who have very keen eyes, you can see premenatally there and her hat on. This is the healthcare provider, and this is the person in the back. Now I'm going to take a moment here just to show you what I've done here with this baby. And this is just it's just a scarf or a kanga that has been wrapped and that I've tied. There are different ways of tying and different ways of doing things. I haven't actually made this bear the correct way. I should take off this shirt, which I hope you can see here, because I want this baby skin to skin. I'm going to put on this diaper that I have made here on the baby because, of course, we don't want, or at least we want to try and minimize the discomfort for the mother, keeping the baby next to her and with the baby's bodily functions. We want to keep this away from the umbilical cord. I've made a hat here, and this hat is made out of a sock. All of us probably have single socks, or you can make it out of someone else, or grandma can knit a hat, and we'll put that on. And now we'll put we'll put this baby skin to skin, the legs spread out to the side on there. Would help if I had better breasts to keep the baby up there. And we'll try and provide this baby with just a little bit of head support. Now, Laerdal actually makes a wrap. The pattern for making the wrap is available, not from Laerdal, but we have that in some places. They would have people in the community actually sew some of the specialized wraps, an income generation project for the community. So we've got this baby who's relatively stable, and this just shows that even men can do this. And if we wanted to take this, even if it's the mother, we could take dad's shirt and put that around that. So you got dad's sock, which is clean, and you got dad's shirt to help provide the baby with increased warmth. And of course, that helps people feel involved. There are exercises with all of this. And this happens to be number 4. There's 6 exercises, works in groups 2 or 3, choose roles as mother, provider, helper, and that has a scenario. 12 hours after birth, a 32-week, 1,700 gram baby who's otherwise doing well, doesn't feed well for the breast or cup. Mother's anxious about tube feeding and would like you to teach her how to do this. And this takes you through how to do this. It's got a check sheet that you can use for the provider or for the mother when she's the provider on there. This is going to be gone over in more detail in a subsequent teleconference. So I only want to indicate that there are a variety of simulation exercises to help assist the learning. The other thing with these exercises is that they can be copied and repeated. Learning is more than just attending one session, one course. In order for learning to be effective, you need to consolidate knowledge and skills either through frequent use or frequent practice. And so with this, there are some practice cards that help facilitate that. They basically look at this and tell people what to look for. Introducing yourself, washing your hands, informing the mother, measuring the amount of feed, etc. So we're going to leave this for right now and provide ongoing maternal education and support. This is a slide just recently taken from Tanzania. Here's a mother, her babies don't have hats on, although the mother does. It actually was fairly warm in the room, but she's got twins. And this healthcare provider, the nurse, is kind of helping this mother with her twins, which are a challenge with kangaroo mother care. We've got an example teaching schedule for the mother as a job aid, starting about 1 hour after birth, going through the preparation to discharge, and then having post-discharge follow-up. And it's important to have that post-discharge follow-up on there. We want to emphasize things for the mother, but also can learn as healthcare providers how to prevent infection. This doesn't replace the need to wash your hands regularly and to keep the surroundings clean. I'm going to skip over this inserting a nasogastric tube because that's going to come later, but talk a little bit, that's going to come in a separate teleconference, but talk a little bit about the mother assessing the baby. Well, now mothers assess their babies usually every time they feed the baby, and we're going to have them assess activity, which includes tone and feeding, breathing, the color, and the temperature. Do the head and feet feel warm to touch? But at least once per shift, someone needs to review that with the mother. How is it going? Some healthcare provider needs to do that. We also want to know the intake, the volume, frequency, the tolerance of the feeds, the output, the wet diaper stools, and we're going to weigh the baby daily until the weight starts to increase, and then every 3 days. The basic thing that we want to do, and it's at every time, is the baby well? Continue care, adjust the volume of feeds as needed. Are you uncertain? It's a change from previous or not clearly normal. Well, we might want to change support or assess the baby more frequently. Or if the baby is unwell with a major problem or danger sign, seek advanced care. Now that care may actually be in the same institution, or in some cases it may require transfer to another institution. There are babies who are sick, get better, and move into kangaroo mother care, and there are babies who are in kangaroo mother care and still get sick and need to be moved back to more advanced care. We try and assist the mother by setting up mechanisms by which she can record her observations on there. This is just an example of an observation form. It would be better for this to be useful for the situation where you're using it, and different hospitals will have different forms on there. This is neither the best one or has been trialed out. It's only there as an example that you need something on there. As we get ready for discharge, we try and look and see what is it that we can do to help get the baby safely home. This is one side, this is the other side of a pamphlet that's adapted from Essential Care for the Small Baby that provides visual evidence then what to do and what not to do. The cord care. Well, now this is set up so if you want to change cord care to whatever that is in Swahili, you can do that. Review mother's breast problems, and we put some information on the mother's breast because the status of the mother's breast not only affects the baby's nutrition, but sometimes the baby's latching on properly is what's necessary to reduce the trauma to the mother's nipples and cracked nipples. Danger signs to seek health care immediately. I'm sorry this doesn't show up as well as it does on the original, but that's probably me trying to adapt things for this slide. Danger signs for the mother. And then on the other side, emphasizing clean hands, clean surrounding, keeping the baby warm, breastfeed, don't bottle feed or feed tea or a variety of other things, assess your baby, and return for immunization and weighing. When is a baby ready for discharge? Well, when the baby's breathing well, the temperature stable, the weight gain is adequate over 3 consecutive days, he has successful breastfeeding or sometimes an alternative method of feeding, the mother and the family are confident, and that you've arranged care after discharge for the baby to be assessed twice a week until the baby is 2,000 grams, once a week to 2,500 grams. The most important part of this program, I think, is to share information with healthcare and the community. All of us love to see our success, but we want to see if we're improving. And so many places will actually do the postnatal or post-discharge care in the same KMC unit so the same staff can see the baby again. If you don't, you want to share information with those who provided the care, but also share your success with your administrators and with others in the community so they will realize what an important part of input kangaroo mother care can provide to babies that are often somewhat marginalized in the society. So I'm going to stop there and ask if there are any questions. I don't know whether anyone has joined us, and if not, and you're viewing this yourself, stop and ask your questions among yourselves. What does this mean to us? How can we do this? This can certainly be done without the educational program that we're putting together in pilot testing. We think that the program may assist in that, and it should be available later in the year when we've had further pilot testing. But please don't wait for that. Look and see what you can do yourselves and how you can do that, because this saves the lives of newborn babies who are small and otherwise well. Thanks very much.